Okay, hello. So today we're going to talk about healthcare insurance and reimbursement methodologies. These are the audio lecture notes for Chapter 2. When we talk about healthcare insurance, and I'm on slide number 2, we're talking about third-party payers. Okay, if you've taken insurance processes or introduction to healthcare services, any building and coding classes, you should be pretty familiar with the different types of insurances and even some of the ways that those insurances are reimbursed. So when we talk about insurance concepts, in order for insurance to work, and I'm on slide number 3, there are at least 4 basic characteristics that should happen with those insurances. And so those characteristics are listed above for you on the slide. One of the ones that I want to point out is what we call indemnification. Indemnification basically is reimbursement to the insured if a loss occurs. Okay, so for an example, how does that apply to health insurance? Indemnification takes place when the insurer, and when we talk about the insurer, I-N-S-U-R-E-R, we're talking about the actual insurance company. So let's just say Blue Cross. So indemnification takes place when Blue Cross, and I'll use myself as the insured, when Blue Cross pays me or Blue Cross pays my provider in whole or in part for the expenses related to my illness or injury. So when I go to the doctor and I pay for an illness or injury that I have, Blue Cross reimburses either me or the provider for those services. Okay? That's basically what indemnification is. Now, when it comes to insurance programs, there are 2 problems that often occurs, and they do occur often. One of them is adverse selection. One is moral hazard. These 2 terms should be familiar to you. You should have heard them before. But let me kind of give you a recap on them, or give you an example so you can pretty much better understand the concept. So adverse selection says individuals and businesses that are more likely to have claims are more inclined to purchase insurance versus those that are less likely to have claims. Okay? So let me give you an example. In your book, an example was given about a surgical procedure. A person that doesn't have insurance, if I'm a person that doesn't have insurance, but I need a surgical procedure that is very costly, for me, I'm going to likely see if I can find me some insurance if I can afford it, because I know I have this procedure that needs to be done that's going to cost me some money. Versus if I was an individual who did not need the surgery, I'm less likely to purchase insurance. Okay, so I'm going to say it again. If I was a person that needed a costly surgical procedure done, I'm going to go and try to find me some insurance to help cover the cost of that procedure. Versus if I didn't have to have the procedure, it wasn't necessary, and I could get by without purchasing insurance, that's what I would do. That's called adverse selection. And I can give you another example that the book gave. Let's look at a 20-year-old versus a 60-year-old. A 20-year-old person may not purchase insurance. The likelihood they wouldn't, but that 60-year-old person would. Why is that? Because the 60-year-old, they're much older. So, when you start reaching that age, your body starts deteriorating. Things start breaking down. You start aging. You're at a much greater risk due to the age. So that 60-year-old person is more likely to purchase insurance. 20-year-old, oh, I have my life, ahead of me. I'm young, I'm innovative, everything's looking good, working good, bones, you name it. So what I need insurance for? So that's what adverse selection is. It's like the individuals who are more likely to have claims are usually the ones that will purchase the insurance. Versus the opposite of that, moral hazard. Moral hazard is individuals, or occurs when individuals are more likely to use unnecessary health services. And they're using these services with no intentions of paying for these services. So it's almost like the moment I get a headache, I run to the doctor, run to the doctor, run to the doctor, run to the doctor. Here's the thing. This is what has caused so many so many physician offices to start collecting copays. You have too many individuals that will run to your office once, twice, 3 times a month for any little bitty thing. They know that there's a copay every time that they have to go. So what used to happen doesn't happen now. What used to happen is you would go and they would bill you for the copay, or you may, if it's a $25 copay, they may say, okay, well, can you put something on it? You may say, oh, I can put $5 or something, but they never get that other 20 from you. And since then, you've made another visit and another visit. So now you're just kind of trickling along, when in actuality, you really should be paying your copay prior to seeing the physician. But that's not happening. Okay? That's not happening. So, moral hazard is a issue for insurance companies, because it's almost like you have more individuals that are making claims, but services are not getting paid for as they should. Okay? So hopefully that makes sense to you, where that'll kind of give you a little bit more insight on adverse selection moral history. On slide 2-5, or on slide 5, underwriting provisions. Most of the time you hear about underwriting when you have individuals who are trying to get life insurance, or maybe even health insurance through an insurance company such as that can be used for automobile, State Farm, Alpha. That's normally where you kind of hear a lot about underwriting provisions. Most of the time when you get insurance through your employer, you usually bypass all of that. Okay, so basically with employers, it's just a matter of going through a benefit period. Okay. Slide 2-6 just pretty much kind of recaps what I talked about with moral hazard. Another term that you can look at for that is overuse, just overuse of health services. Usually, and I have a list down there at the bottom, is usually protected when you have deductibles, copays, and co-insurances. That usually kind of stop individuals in their track. It doesn't totally solve the problem or the solution, but it's a start. Third-party payers, slide number 7. We already pretty much know what that is. We're talking about private insurers and public insurers. So we're looking at private insurers being like Blue Cross Blue Shield, your commercial insurer, your self-insured people, and public insurance, government insurance, Medicare, Medicaid. But they're still classified as a third-party payer. On slide number 8, it goes on to talk about managed care plans. Okay. HMOs, PPOs, POS. All of these should be very familiar terms to you. Basically, managed care plans is exactly what it says in bullet number 1. It's basically to try to provide or combine provision of services with the way organizations function. So although an organization or an entity or a facility is providing you quality services, what has to be also looked at is not only the way that they're providing those services, but making sure that in combination with the insurance aspect of it, all of it combines itself together. In other words, that's why students are taught in their coding classes what you code for a patient has to make sense in relation to the diagnosis. Because what you don't want to find yourself doing as a healthcare facility or even as a physician is charging for services that are unnecessary or ordering services that are not necessary. Okay, so managed care plans help to offset a lot of those type of issues. When we look at slide number 10, it goes and talk about some of the different types of reimbursement methodologies. So we know FFS, fee for service. This is pretty much where amounts of services are provided. So that could be three different things: charge-based, cost-based, or prospective payment. Basically, you pay the provider for the services they render. You pay the facility for the services they surrender. Okay? Now, when we talk about capitation, if you're ever in a situation where you're dealing with capitation payments, those are like set fees. So it's almost like you may have a procedure done, but if your insurance has capped it at so much that they're going to pay out to the provider and so much of a percentage they're just going to cover overall, it's where the payer pays allowable cost. So when claims are being sent through patients, there is a box on their claim form that says the physician accepts the assignment. The moment he hits yes, he accepts the assignment, pretty much he is agreeing to whatever the insurance company reimburses him. That is what he has to be satisfied with as far as a reimbursement back for the services that he rendered. Okay, so let's look at, we've talked about capitation. That's on slide number 14. So let's look at slide number 16 real quick. Medical coding. So coding is the first step in the reimbursement process. Okay, I have that as the very first bullet up here on the slide. Why is it necessary? It is necessary because that is how facilities get paid for their services. And when I say facilities, I am including everybody, okay? We all work in that facility. We all reap the benefits from working in that facility. So you want patients to pay their bills. You want coders to make sure that they code correctly. You want your insurance people at the front to make sure that they verify that these individuals have insurance and that, you know, you're not giving services and they're not insured, but they gave you a card to say they are, but the card is expired or they no longer have the insurance. You want to make sure all of those things are clear so that you can make sure the facility receives the proper payments that they're supposed to receive for the services. Now, there are three different types of codes that are commonly used by providers. I have them listed for you: the ICD, the CPT, and the HCPCS code. But you know, the HCPCS, in other words for that, is the HCPCS. So you have two different types. You have both diagnostic and you have procedural coding that has to be done on all patients for their claims. So when we talk about ICD codes, slide number 17, these are pretty much the codes that help to identify diseases, symptoms, or injuries that were associated with the patient when the patient came to the facility. Okay? Again, every code should match up with the diagnosis. And that same code should also match up with the procedure used to treat that diagnosis. So if the doctor diagnosed me with hypertension, my medical code should be a diagnosis for hypertension, and if he does a procedure on me, that also should coincide. So my procedure shouldn't be the x-ray of my foot, because the x-ray of my foot has nothing to do with my hypertension. Okay? But like, say for instance, if he did a stress test or an EKG or something of that nature, that will work. Okay, so it has to make sense. CPT code, slide number 18, of course, what I stated before, this is used to specify different procedures used on the patients. Okay, Medicare reimbursement methods. We know Medicare and Medicaid is pretty much governed by the government, of course. Not everybody qualifies for that. Most of the time, your Medicare patients are usually 60 and above or 65 and above. A lot of times, your Medicaid patients are usually those same ones that are already getting some type of government assistance. Hospital inpatient services, slide number 21. IPPS, that's the Inpatient Prospective Payment System. That is the payment that is used for inpatient services. Normally with inpatient services, there's a form called the IBU04 or IB04 form that is used to help with coding for inpatient services. So hospital coding and the physician coding they're similar in ways, but then they can have some ways that are a little bit different. Okay, physician services. Physicians charge their services based on a fee schedule. That's slide number 23. Okay, not every physician office or physician, but the one thing that you have to remember as a manager is the reason you have to understand the reason why you set rules the way you do when it comes to insurances or getting a lot of or not even just when it comes to insurances, but when it comes to just providing quality care. Your job is secured when your physician is satisfied. I'm going to say that again. Your job is secure when your physician is satisfied. A physician, and don't fool yourself, when they know their clientele, they pretty much can tell on their finances, and when they're looking and reviewing the books, they can tell when services are being rendered the way that they should, because they know what it is they're generating in versus what's going out. Your quality of service has to be of such where, as a person that has insurance or as a person that doesn't have insurance, I know that either way, your level of service is going to be of such where I cannot tell a difference. It should never be that you treat me different because I don't have insurance or I do have insurance. You shouldn't. Okay? So the one thing I want you all to understand is when you get ready to go into your jobs and you're getting ready to make some changes, be mindful of the different changes that you make. Okay? To me, requiring the copay to be paid or the co-insurance or the deductible is a good thing to me. Because when you're dealing with an individual that don't have insurance, you got to have a way of securing that payment for those services that you are about to render. Okay? There are going to be some times you're going to have to make some tough decisions when it comes to, patients that need to be seen and bills that need to be paid. There are going to be times you got to make some tough decisions. But the one thing that you need to always be mindful of, make sure your staff is well trained, especially your front office people, because those are the individuals that has to verify all of this insurance for you. So there's nothing wrong with, making sure that you verify with each patient, hey, have your insurance changed? Because, a lot of times people change insurances once a year. There are some that may change it every 6 months. And a lot of times those changes occur because either something happened on the job. A lot of times there could be a job loss. Then a new job come. If I'm at one job I had Blue Cross, I may go to this new job, I got United Healthcare. So you got to make sure that your front office people are trained very well. Make sure that you hire in the best individuals for your billing. If you choose to do billing in-house, like I said, some doctor's office does their billing outside of the facility. Okay? That pretty much recaps us up for Chapter 2. Again, as a reminder, make sure you do go back and read the chapter, as all concepts are not discussed in the PowerPoint slides. I just hit the most highlighted points. If you have any questions, always feel free to reach out to me. Thank you.